So, hello everyone. We're going to go ahead and get started. I know that folks are still joining us, and we anticipate there will be more, but it's a little after 12. So, welcome. We're really happy to have you all here. I'm Kathleen Zegda. I'm the Director of Community Research and Evaluation at the Public Health Institute, and we're really looking forward to today's panel. And we know that there's been a lot of questions that have arisen with the evolving nature of COVID. And so we feel really grateful to have the expertise and knowledge of our panelists who are here today to be able to answer some of the questions that people are having about what is the future of COVID to the best of people's ability right now, knowing it continues to evolve. So a few agenda items or housekeeping items that I just want to mention before I turn it over to today's moderator. So if you're having any technical difficulties or need help, please send a direct chat to one of the hosts. So you could send it to me or one of the other hosts here. I'm Kelly Waldner. For folks to know, we are recording the webinar. The recording will be emailed to registrants and posted on our website, the Public Health Institute of Western Massachusetts. And then also when the webinar ends, we'll ask that you please complete a short survey about your webinar experience. We really want to make sure that our webinars are meeting folks' needs and improving them as we can. It'll only take 1 to 2 minutes. So we'll share a link at the end for you to complete that. So now I'm going to go ahead and turn it over to our moderator. So Dr. Airín Martínez is the vice president of our board at the Public Health Institute of Western Mass, and she's an assistant professor in health policy and management in the Department of Health Promotion and Policy at the UMass School of Public Health. Her research examines how socio-political conditions and institutional racism produce chronic disease disparities among Latinx immigrants and their US-born children. And so we are grateful that she is joining us today to moderate our session. I'm going to turn it over to you, Airín.
Thank you so much, Dr. Zegda. It's my pleasure to be here, and it's nice to be here with everyone. And I'll introduce our expert panelists. So first is Dr. Amanda Westlake. She's a physician at Baystate Mason Square Health Center. She's also the director of the COVID Outpatient Therapeutics for Baystate Health, as well as the medical director of Baystate's post-COVID clinic. She'll be speaking today about the current status of COVID. Our second speaker today is Phoebe Walker. She is the Director of Community Services at the Franklin Regional Council of Governments, or what a lot of us call FRCOG. She has been a public health advocate for many years, was part of the organizing team for Franklin County's Vaccine Collaborative, and has served on the Governor's Vaccine Advisory Group. She is the recipient of the Massachusetts Public Health Association's 2022 Local Public Health Award. She will be speaking about cutbacks to COVID services and the implications for Western Massachusetts. Our third speaker today is Doris Harris. She is the host of Health Matters Radio and also the health editor of the Point of View community newspaper and a consultant with the Public Health Institute of Western Mass. She has been recognized for her community outreach and advocacy. She recently received the 2022 MLK Social Justice Health Advocate Award for community outreach. She will share learnings from doing COVID community outreach. Just for you to know, notice that in the bottom of your Zoom menu bar, there's a Q&A bubble. It should be like the second to last little button, and you could submit questions there. And that's how we'll be able to answer your questions at the end of the webinar. Also know that we'll have the speakers go first and give their presentations, and then we'll have a Q&A session after where we hear from the three speakers. You can submit your questions again in the Q&A feature on the bottom menu bar on the Zoom platform. We also have questions that were submitted during registration. So if some of you are shy and don't have any questions, we have some already that you may be thinking about. All right, so I'm going to go ahead and turn it over to our first speaker, Dr. Westlake. Thank you.
Thank you so much. And thanks for inviting me to share in this presentation today. As was mentioned, I am both a primary care doctor and I work at Baystate Mason Square Neighborhood Health Center. And I'm also an infectious disease specialist working for Baystate, and I've been specifically involved with COVID in both the hospitalized populations and now am the director and coordinator of outpatient COVID treatments. So my first task today is to situate where we are in the pandemic. And to do that, I will share my screen. And now you should be able to see the COVID-19 interactive dashboard on mass.gov to help us understand where we are in on April 29th. We are in the midst of a small surge that's driven by the Omicron subvariant BA.2. And this surge has been small compared with prior surges thus far, but still hasn't peaked yet. And this data helps put into context where we are based in vis-a-vis prior surges. So if you look here at the 7-day average of confirmed cases, right now we're averaging 2,200, whereas at the height of our Omicron surge on January 9th, we were averaging 23,000. And back here is the Delta surge at nearly 2,000 cases per day. Unlike prior surges, what we're seeing is that hospitalizations are lower, and thankfully deaths have lagged even more. Another way to think about the current surge is how does this map onto our different regions of Western Mass? And right now, Hampshire and Berkshire counties are leading the pack, whereas Hampden and Franklin counties are somewhat less affected. And another way to think about this is what individuals are the most affected by our current surge. And so during this BA.2 driven surge, you can see that interestingly, the predominance of cases are in the 20 to 29-year-old age group, who account for only 15% of the population, but 23% of COVID cases in the last 2 weeks. So that, I'm going to stop sharing my screen there and move to talking about why this is happening right now and what the BA.2 strain is. So COVID is going to continue mutating because that's what viruses do. And since the end of December, the predominant strain has been Omicron. And originally it was Omicron BA.1, and now is a subvariant called Omicron BA.2. How are these strains different from prior strains? Primarily because this virus is much more infectious. And I think the way to conceptualize this is that we now acknowledge that COVID is primarily spread via aerosols, but the Omicron surge is even more infectious. Uh-oh, I have an invader in my Zoom. I have an invader. I have a 2-year-old invader. Okay, so the Omicron surge strain is even more infectious. And so when you think about aerosols, I think the one way that is most intuitive to think about this is to think about cigarette smoke. So everyone has experienced how that if someone's smoking in a room, you can experience and smell that cigarette smoke across the room, regardless of whether or not you're wearing a mask. And that is how Omicron is transmitted. It is a tiny aerosol that is suspended in ambient air and that fills a space. So that's why it's so much more contagious. And Omicron, unlike prior strains, has an ability to evade immune protection, which means that your protection that's conferred by prior natural infection or by prior vaccination is not fully protective against infection, although it remains protective against severe infection. So that was the initial Omicron BA.1 strain, highly infectious, on a population level, thankfully less severe. BA.2 is even more infectious than BA.1 and of equal severity than BA.1. So that's where we stand right now, and upwards of 95% of the current infections that are transmitted locally are BA.2. In terms of testing and treatment, we're in a good place right now in terms of treatment because we have 3 treatments that are able to be accessed by people who are not ill enough to be hospitalized, and these are widely accessible. And those 3 treatments are an oral pill called Paxlovid, an intravenous treatment called remdesivir, and an intravenous treatment called monoclonal antibodies. And because now these treatments are in ample supply, whereas during the January Omicron surge, these were very constricted in terms of supply, and we had to do a lot in terms of directing them toward the highest risk patients because they were a limited healthcare resource and we were trying to allocate them in order to make the biggest public health impact. Now we're in the place of having a boatload of Paxlovid, remdesivir, and monoclonal antibodies. So anyone who is eligible for treatment should be able to access these. What does it mean to be eligible for treatment? Well, the majority of the American populace is eligible for treatment because all eligibility means is that you have 1 or more risk factor for severe COVID-19, which encompasses such common conditions as hypertension, diabetes, even being overweight with a BMI of just 25.1 would make you eligible for treatment. So this is a very inclusive and widely inclusive list of eligibility criteria. I think our major public health message about this needs to be that these treatments are effective only if they're deployed early. And by early, I mean within 5 to 7 days of symptom onset. So the other thing that has made treatment much more accessible is the accessibility of home-based point-of-care antigen tests, because you don't need a PCR test in order to qualify for these treatments. You test yourself at home, you have consistent symptoms, you have 1 or more risk factors for severe COVID disease, and you're eligible for treatment. And of these 3 treatment options, the preferred treatment and the one that's most widely accessible is Paxlovid, because Paxlovid is a pill that you self-administer at home and that you obtain from your local pharmacy. So that's where we are with treatments. In terms of vaccines and boosters, I'm sure you all are aware that people who are age 50 and older are eligible for a 4th dose of vaccine, otherwise known as a 2nd booster, as long as they're more than 4 months out from their 3rd dose. I think that the way to think about boosters is that the majority of the protection that you have against the most important outcomes for COVID-19, hospitalization and death, is conferred by doses 1 and 2, or by prior natural infection combined with 1 or more doses of vaccine. Thereafter, the incremental benefit in terms of hospitalization and death for any vaccine is diminishing. So the boosters are much less important than the primary series, although they do give you some incremental benefit. They do not confer complete protection against infection for 2 reasons. 1, because the effect wanes over time, and that effect wanes over the course of months. And the second reason is that the virus itself is continuously mutating. And so as it mutates, new strains may not be fully susceptible to the immune protection that is conferred by prior vaccine. So I think the main messaging on vaccines continues to be that the primary series is the most important. The boosters confer some incremental benefit, but the benefit against preventing infection entirely is short-lived, whereas the benefit of protecting people from severe disease and death is durable. And I think that concludes my remarks for now, but I'm happy to take questions in the chat.
Thank you so much. And now we will have our second speaker present, Phoebe Walker.
Hi, everybody. I can't see you, but I'm glad you're here. And it's nice to be here with this wonderful group of people. So I work in rural Franklin County, where among other things, I manage a rural health department that does contact tracing, vaccination, and of course, all the other important local public health functions like health inspections. And I'm also part of a coalition for local public health, which is a group of all the public health associations that in Massachusetts that meets together every other week with the Department of Public Health and has tried to really advocate for the changes we see necessary during this last few years. So I think one thing I wanted to contribute in addition to what Dr. Westlake said about where we are now, because it seems like one of the points of what we're doing here is just to talk about where we are now. And I wanted to share one screen with you, and that is, this is the wastewater. Can you guys see it now? This is the wastewater treatment website for the entire country from BioBot. So the wastewater testing, as folks may know, there's wastewater testing going on in all different cities around the country. And this one allows you to look and see by region what kind of COVID they're finding in the wastewater. And down here, you can go, I clicked Massachusetts, and you can see here by county. So important to note, rural people, that this does not include anybody's septic system, right? So these are only taken in environments where people are on sewer. And in many cases, so for instance, in Berkshire County, this is likely just Pittsfield. I don't know for sure, but I know that very soon in the next week or so, there will be a Franklin County one here. It will be just Greenfield who is on it. But it answers a very important question that many people have, which is, now that everyone's testing at home, how do we know how much COVID is really happening? And this allows you to look and see sort of those charts actually mirror the charts that Dr. Westlake just shared pretty well. So the shape of the charts is pretty similar. So that is kind of reassuring because it makes us think that there isn't some other enormous surge going on that we don't know about. So I wanted to share that, and then also talk a little bit about at-home tests. So I think for where we are now in the state, we're really relying a lot on the at-home antigen tests, and they are not the same as a PCR test, but they can be very helpful. And so it is really important that everybody know how to get them and how to use them. You know, it is not the ideal test. And I guess Dr. Westlake, please leap in here if I'm saying anything wrong. But you know, this is not the definitive way to find out if you are going to have COVID in a day or two. Like, they're only testing you in the moment that you're being tested, unlike a PCR test, which is very sensitive and can sense that you are building up a viral load of COVID. The antigen tests don't work that way. So that means you need to have a few of them, right? You need to have a bunch at your house. At this point, all Massachusetts insurances cover 8 a month. So everybody should be able to go to a pharmacy, take the tests to the pharmacy, not to the front desk, and say, I would like this, here's my health insurance card. In some pharmacies, the rules can be a little different. I know that when we have a colleague of mine called all of the pharmacies in Franklin County to ask what to do. And at the CVS, people were told, call first, say you're coming in, or order it, the pharmacy, and then go pay. Whereas in other places, you just go to the pharmacy with them and pay. But it's important to know that everyone who has insurance can get 8 a month of these things paid through the insurance. This is new for Medicare. For a long time, people weren't able to figure out how to do that, but that is now finally working. And Kelly's going to put a link in there to show you the news about the Medicare coverage, because I think that's important for us to help people understand how that works. So I wanted to just talk about the antigen tests. And do you want to just step in for 1 second, Dr. Westlake, and say, like, what's the most effective way to use them if you don't have access to a PCR, which many of us don't anymore?
Sure. Antigen tests are excellent at detecting COVID, but they are meant to be used in series. So because the antigen test will only detect COVID at the moment at which you have the highest burden of virus in your nose, that very early in the illness where you're contagious, you might test negative falsely because and then 12 to 24 hours later, you'll test positive. So if you have the onset of symptoms or have a known exposure, the most effective way to test with an antigen test is 2 tests in series separated by 24 to 48 hours.
Thanks. So I think we're in this interesting place in the state, right, where we're sort of ramping down all the emergency stuff, all the big stuff that the state funded, and we're trying to learn to live with this, and the state is trying to have us learn to live with it within the structures we're all used to, getting our tests from places we normally go anyway, getting our treatment from pharmacy, not getting our vaccines at our doctor's office or our community health center or our pharmacy again. So we're in this transitional moment where we're having to relearn the skills that we had just learned to deal with the emergency, with what the state had put together for emergencies. And, in terms of impact on Western Mass, I personally was very disappointed to see that the only 2 Stop the Spread sites left in all of the 104 towns in Western Mass are in Springfield. That does not seem fair, frankly. But I think we are actually working pretty well with Curative, a private sector vendor. And like I said, I think the state is trying to move us into systems that are going to work for longer. And so right now, Curative has a site in Deerfield. It's opening one in Greenfield. I know that Berkshire County still has another testing site that isn't state supported. So there are still access to PCR tests. They're nowhere near as easy as they used to. More importantly, there isn't the COVID emergency leave anymore. And that is a problem for a lot of people we talk to, as is the much more limited time to get the kind of test that your office will believe you that you have COVID if you need to be tested. So those are 2 things I feel like we need more access to PCR testing at off hours. In places outside of Springfield, and I don't know how comfortable you guys are with the hours of the ones that you do have there. And I also think we really need more access to the free antigen tests. Even though everybody can get 8, not everybody feels comfortable going back and standing in line at the pharmacy. Not everybody can actually make that work. And so I know that we've been able to give out thousands of free tests here, the antigen tests at food pantries, at public health nursing clinics, places where people who need access and struggle to get into a pharmacy can get them. So I think continuing the state funded flow of free tests to various places would be really good. And I know I'm running out of time, but I want to say that the other thing that we really need to be doing is learning from what just happened, right? We really need to be figuring out what went wrong, what can we do better? And all around the state, people like Senator Comerford, I know, is here watching and has been chairing the COVID-19 and Emergency Preparedness Committee. And thank you for all of your work on that, Senator. We need to crystallize the lessons from this emergency, and we need to get ready for the next one, because we can't be found like this again. We can't be as subject to the whims of what the state, decides to do as we were before. And one of the most important things, in my opinion, that we're doing in that field is we're changing our local public health system in Massachusetts. We are recognizing that there were very few public health nurses available. We had to stand up a $160 million program to do contact tracing, that money just left. It's not available to be invested in Massachusetts's local public health system. So very excited about the federal funds that are being invested in the system, and very excited about the good prospects for the SAFE 2.0 bill, which is a bill that would really change how we look on the ground. So next time we're more ready, we have more capacity to help our communities. I think that's what I have to say. I hope I didn't go over my time. Thanks.
Thank you so much, Phoebe. You did not go over your time, actually. You were shy 1 minute. So yeah, just like Ms. Walker had identified, we'd like to acknowledge the attendance of State Senator Joe Comerford, who's here. Thank you so much for coming, and thank you so much for your support in terms of many topics on public health, not just COVID-19. So our last speaker today is Ms. Doris Harris. Whenever you're ready, the floor is yours.
Thank you. Thank you, everyone. I'm Doris Harris, a public health consultant, host of the radio show Health Matters. But most important, which I didn't acknowledge, is I am the co-chair of the Springfield Black COVID Coalition. I want to share with you what I found in the community. I found that a lot of people were traumatized by this pandemic and therefore acted in a way of flight, fright, and fight. Therefore, having those kinds of responses, they tend to not do anything to move forward and helping themselves with gaining understanding and knowledge regarding the COVID vaccination. However, I want to say that there was a lot of media overload with this particular community, which allowed them, because it was just so much information shared. It was information shared from leaders, information shared on the TV, from political, as well as health organizations. A lot of people became so overloaded that they became defiant. They didn't trust. So again, moving forward was very hard. One of the things that I think in order to sustain moving forward is to provide preventative and educational information. Provide information and spaces where people trust, and also to provide information to people that look like the individuals that you're talking to. Public Health Institute, we did go in various locations. One that I'm proud of is there was soccer teams that was happening on a Saturday, and just sitting down with the parents and be able to share information with them. Talk about vax hesitancy, find out why, what is their concern, what is the issue. We still need to have education again and preventative information. Preventative information doesn't start when you're sick. Preventative information doesn't start when you need to get a vaccine. Preventative information starts when you're born. We have to change some of those attitudes and behaviors. What I like to do is to motivate and empower people where they could be their own health champions. And how do you do that? You do that by validating the person. You do that by listening to the individual. You also do that by providing them information that they can understand. For some of them, they don't even know what CDC means. So to allow them and give them information on CDC and why it's important that CDC is here is to help them. Also to go into the community and put flyers and education materials in barbershops and convenience stores and in places where the community frequent. I met in my travels a convenience store where this gentleman was so kind, where he had a credit for people who couldn't pay. As I talked to him about COVID, he was very knowledgeable and agreed to give people information so they would be able to maneuver themselves where to get the shots. Churches are also important, and I would recommend that we bond with churches, but we also train the leaders within the church. Believe it or not, I found that a lot of the African-American churches that I frequent had a health component with retired nurses who wanted to do things, who wanted to be active. So again, setting up training and education for how they can move forward and helping the parishioners with getting the vaccine. Having a coalition, I do belong to a coalition, but a coalition that's made up of primarily community members, what I call unsung heroes, such as that convenience store gentleman. and also people who are survivors of COVID to speak and support to the community. That was very effective. I had a show of a survivor who was also, he worked in the school system as well as he was very much a community activist, and he shared his story. But what I got most of all from him, he talked about his fear initially by not moving forward with getting the COVID. And he encouraged, especially young Black and brown men, that it was important for them to do this for themselves. We need to emphasize that not only are they doing this for themselves, but they're doing it for family, and they're also doing it for the community at large. A lot of times they don't understand that. There was a lot of conspiracy theories going around, and people became very defiant, and they also felt that if you did get the vaccine, you were somewhat of a sellout of government. You need to train people to and change behaviors on how they can move forward to be their own again. I would call them, you're my health champion, you're my health warrior. I want you to take a step for yourself where you can provide for your family. I use an analogy of when I go on a plane, the stewardess will tell you right away, if anything happens, you are to put that mask on yourself before you put it on your child. That way you can best help your child. So I want to say that it's important to move forward by empowering the community, listening to them. Don't put them all in a box and think that, well, they're doing this because of the Tuskegee Institute. They're doing this because of that. If you can listen, and if you can empower, and if you can motivate, you will see that individuals will make the best choices for themselves. They need to have their voice heard. I want to leave you with this quote that I got from the great late Maya Angelou. And I use this every day when I'm out in the community. And it reads like, people will forget what you said. People will forget what you did, but people will never forget how you made them feel. And I think if you take that and you reach out with integrity, with dignity, and also with comfort, you will find that you will get more positive results. Thank you.
Thank you so much to our wonderful panel. I was even taking notes during the webinar. Okay, so now we're going to open up the discussion for Q&A from the audience. Several of you have already posted questions in our Q&A function. If you still have any pressing questions or anything that you'd like to ask our panelists, please feel free to leave your question on the Q&A button. It's on the lower menu bar on Zoom. Okay, so I'm going to go ahead and ask one of the questions that was submitted by one of our attendees. And yeah, and I think that this would be good for any of the panelists, but maybe Dr. Westlake. Is there a way to help people with disabilities and the elderly continue to get virtual doctors visits when they are sick to go to the doctors?
I think that one of the positive aspects of the way that the COVID pandemic has shaped our health system is that it has made healthcare much more accessible for many people through telehealth. And telehealth is here to stay. And so I think that that's never going to go away. And there's always going to continue in the future to be a way to access medical care through either phone or video visits, assuming that you have an established provider. If you don't have an established provider, then you're working through all the urgent care mechanisms to access care.
actually related to access, and there were a few questions about this also from people who submitted questions as they were registering for the webinar. What are options for people who are uninsured to obtain Paxlovid for treating COVID-19 or for obtaining the antigen test?
Thanks for that question. I actually wanted to again share my screen to show an amazing resource that is from the Massachusetts Department of Public Health. So I should have stated explicitly that Paxlovid, which is the COVID-19 antiviral pill, is available free of charge and regardless of insurance status. So any provider can prescribe this medication, and it can be sent to a number of commercial pharmacies. So using this locator, which is on the mass.gov website, you can look for a location. So this is the zip code of my health center. And this will show you pharmacies that have Paxlovid in stock that are within your geographic range. So here this shows us that right down the street from the Mason Square Health Center, there's a Walgreens that has 79 courses of Paxlovid in stock, and the CVS across the street has 15 courses. And so at any of these pharmacies, you do not have to be registered with that pharmacy. You do need to have no insurance on file, and this is free of charge with zero copay. And because by definition, the people who are taking this medication are actively infectious, many of these pharmacies also offer delivery services. Similarly, with the intravenous treatments, they're currently being offered through Gotham's, which is an emergency response company that's contracted through the Massachusetts Department of Public Health. And they run a mobile COVID treatment site out of a trailer in Holyoke, in Pittsfield, and in Athol. And in those locations, people who are uninsured can receive intravenous treatment with monoclonal antibodies or remdesivir. Does that answer the question?
Yes, it was actually, I'm really happy you shared your screen actually too. So there's a couple of other questions here about using the rapid test. One is from actually Andrea Freeman, the new data to policy action person at the PHI Western Mass. What's a good, easy way to advise folks for using rapid home tests? How frequent if they have no symptoms, before or after certain group events? Thanks. Oh, you're typing the answer?
No, let me answer that one for everyone.
Or
So I actually think that there is very little role for PCR tests for the general public right now. Rapid antigen tests are all that we need. So if you're thinking about testing after a discrete exposure, the incubation period, so the time between the exposure and the development of active infection for Omicron, is around 2 to 5 days. So this is quick. So if you're thinking about after a discrete exposure, I would say test once around 3 days and once around 5 to 7 days. Or test any time at which you develop symptoms. Because any test, this is a kind of statistical concept, but there's a concept of pretest probability. So even without taking the test, how likely is it that the condition is present? If you have symptoms, the test performs much better, meaning that any test can give false positives or false negatives. But if you have symptoms, a positive test is much likely to represent a true positive. So rapid antigen tests perform less well and really should not be used as asymptomatic screening. If you have no symptoms and no exposure, the rapid antigen test does not give you good information. If you have symptoms that are consistent with COVID and especially with a known exposure, or if you're trying to test after a known exposure because the symptoms may be mild, then this is a great time to use the rapid antigen tests and in series. So let's say you start developing symptoms, but the symptoms are mild and you have sort of a mild sore throat. You test on the first day that the symptoms are present, it would be, and you get a negative test, it would behoove you to test the following day if your symptoms continue, because you might have gotten an initial false negative.
Thank you. I'm going to ask one of the questions that was submitted by one of the registrants. Without reporting of home testing, how do we know the true rate of positive COVID-19 cases where hospitalization and death aren't factors?
I think that was part of what I was trying to show with the BioBot data. You know, I think that this is everyone's question, right? We're only capturing a tiny fraction of the people maybe who have it, but you can get the sense of the curve, you know, by looking at that wastewater data. And also a lot of the people who are being tested positive now are being tested positive because they came into the doctor's office for something else, not because they're so sick, but they came in for their whatever surgery that they need to have and they got tested. So I think that wastewater is the best proxy, I think, that we have right now.
So one question that was also submitted by the registrants is, what are plans and or recommendations if we surge again? Precautions have been largely dismantled and people are feeling COVID fatigue. How should we ramp up and respond?
Well,
I-
yeah, go ahead, please. Ms. Doris.
Thank you, Phoebe. I think that we need to still be in the community. I think we need to offer testing as well as vaccines in site where people could walk to, feel comfortable. But also one of the things I didn't say, I think employers should look at people who are in low wage, such as food service individuals and retail, and see if they could get time off to go to testing and also vaccine site without having any type of monetary punishment. Because I found single mothers who were working 2 jobs or people who were working at food service jobs who couldn't go. And then when they got home, they were extremely tired. So I think that's important.
The other thing I would say is just, I mean, the state, I think, has been pretty clear that they're not, it would take a pretty remarkable surge for a state of emergency to be declared again. You know, we are trying to learn to live with this. And so one of the downsides of that is that it's not that it's not that public health doesn't care anymore and can't take steps. It's that responsibility has now come down to the local level, where you are relying on an individual local health department to work. Say, for instance, we had recently a school where there were, 40 cases in a very short period of time, a couple days. So in the previous world, that school would have called DESE, which would have said what to do because under the orders. And now DESE says, the Department of Elementary and Secondary Education, says, talk to your local board of health. So they have to call these 3 volunteers in their town and say, should we stay open? So we are, as their local health agents, we worked with them, the nurses and the agents, to talk it over, and they ordered that particular school back into masks for a week, then let school vacation be a week. And now, things have died down and they're out of their masks again. So I think we have to have these tools and know how to use them and have some sense of when, have an ongoing sense of the danger and the, what the risks are in a particular situation. And then we all know what are the things you can do around masking and vaccination and social distancing and airflow, very important, outdoor socializing, things like that. We have the tools. We are unfortunately relying on a local level messaging about that because the state is done giving those messages.
So if it's left to the local health departments, how can we ensure that there's health equity across regions, especially when there's so much, like we already know there's this east-west, right, inequity. So how do we ensure health equity if we're leaving it up to local health departments?
Well, this is I think a similar question was asked in the Q&A. And I think we are in probably year 2 of probably a 8-year transformation of our local public health system, where there will be performance standards that will come out this summer or fall. There will be workforce credentialing requirements that will come out this summer or fall. And there is federal ARPA funding here to help the communities that can't meet that standard now get up to that standard. But the vision is that eventually everybody in Massachusetts, regardless of your zip code, should be guaranteed a base level of public health protections. There should be a qualified public health nurse on the other end of that phone to answer your questions, you know, no matter where you live, how big or small the town is. So that's the sort of project that many of us are working on. And again, you know, Senator Comerford has been sort of leading that charge with the SAFE 2.0 bill. And Rep. Decker from the Public Health Committee, the two of them chair the Public Health Committee together. I will put in the chat a link to the Mass Public Health Association's information page about that bill. But this is it's a lengthy multi-part effort to sort of make us be like other states, where we finally actually fund local health departments and we hold them to high standards for everybody.
Changing the topic a little bit and answering a question that came in from one of the people in attendance. The question is, for a vaccine boosted person who masks consistently and is more cautious about exposure than many, how concerned do I need to be about associating with a person who isn't vaccinated? Are unvaccinated people much more likely to spread the virus to me than vaccinated people are?
I'll take that one. So I think that we have come to learn what are the limits of effectiveness of our vaccines and what our vaccines do and do not do. And in terms of, I think one of the previous speakers was talking about the lessons of the pandemic. I think messaging and around vaccines has got to be something that we strive to do better with going forward. So what we've learned is that our vaccines work amazingly well at preventing the outcomes that matter most, which are death and severe illness from COVID-19. And they do not work well in terms of preventing infection. And that is a product of the fact that vaccine-derived immunity of the type that would prevent infection from occurring wanes over time, and that the virus changes over time in ways that can evade vaccine-induced immunity. So that is a long-winded way of saying that the people who are, because the majority of our populace is vaccinated, the majority of COVID cases now are in people who are vaccinated. And the presence of vaccine in those people is preventing them from becoming severely ill and often attenuating the course of their illness, but they can still transmit. So in short, vaccinated and unvaccinated people with COVID-19 both still transmit the virus. So using that as a means of sorting people in terms of determining your risk for getting COVID is not a reality-based way to go about it.
Thank you. Earlier in Ms. Harris's presentation, you mentioned about that you're one of the members of the Black COVID-19 Commission, or is it a coalition? I was wondering if you could talk a little bit about how that was formed and how other local groups can create similar community-based coalitions to help disseminate information about COVID-19.
Yes, I was appointed by State Representative Bud Williams to be part of this coalition. And I think one of the reasons why he appointed me is, as I said, I host a radio show on 90.7 FM WTCC and also a health editor. We used to meet on a regular basis and we had a public service announcements for people to join. But what State Representative Bud Williams did is he picked key individuals from the community, such as clergy, myself, maybe other political people who he thought could influence and make changes. I think it's important to do that. I think it's important to bring like minds together. I think it's important because it is an advocate for change and moving forward to do the best you can for your community. The reason why we came together, I think he was looking at what they were doing out east, but also the numbers within a certain area code started to escalate. And we felt we needed to come together in order to protect, primarily it was Black, Indigenous, and people of color communities. So that's what we did. And we were able to form alliance with primary care providers and come up with different activities. I just want to mention, I will be facilitating next Saturday a program which we will have, they call themselves the Black Experience Educators. And we're going to talk about how the pandemic has impacted children and what parents can do to help. So I think it was something that he saw a need. He asked me to come on, and I'm glad that I am part of this wonderful effort.
Thank you. So how is information about COVID-19 being disseminated to non-English speakers or disabled communities? Could any of you speak to that?
Well, the only thing I can say is that there is an organization in Springfield, New North Citizens Council, which is a primarily Hispanic, and they're doing it that way, pretty much the same way that the Black COVID, going door to door, going in spaces, in areas where people congregate and feel comfortable at, and working in that type of way. So I think that for people of color, my experience, it was important to meet them where they were at. They were more apt to talk. They felt free. They felt trusted. So I would, Dr. Westlake is here, is my radio show. I worked at Mason's Green Neighborhood Health Center, and my radio show came out the same thing. I just felt people were coming because they were sick. The whole idea was to provide prevention and education. So I really, truly support that. And I think the same thing works in this situation as well.
We have 4 more minutes left in the webinar. If anyone has any more questions, please feel free to leave them in the Q&A. If not, I think there's one question I think that we should end with in the Q&A that I think is super important. Should I still get the vaccine if the risk is lower and the vaccine is only going to make it less severe?
So before I answer that question, I want to make sure that I address something that Dr. Levin put in the Q&A, which is that Paxlovid does require a prescription from a provider. So it's not that you can be entirely external from the healthcare system, walk into a CVS and obtain Paxlovid. It's not an over-the-counter medication, and there is some rationale to that, although that would facilitate access. There are a number of medication interactions that could be dangerous if prescribed to someone who is taking medications that interacted badly. So you need a provider, nurse practitioner, physician assistant, physician to prescribe this medication and in order to access it. But once you have that prescription, it is available free of charge and without insurance. So getting back to this question, should I get the vaccine if the risk is lower and the vaccine is only going to make it less severe? I think that this is part of framing where we are in the pandemic. There are 2 ways to obtain immunity to COVID. One is through natural infection. The second is through vaccination. And the most well-controlled and safe means of obtaining that immunity is through the vaccine. So I think we are starting to have a reckoning with the fact that every member of the human population who interacts with society will encounter COVID. We will all encounter this. This is inevitable. The way to encounter COVID is when you have vaccine in your body, because that will ensure that you protect yourself against those severe consequences of severe illness, including critical illness and death. And while there are well-recognized risk factors for severe disease, age is the most potent, but also diabetes, hypertension, overweight and obesity, and any chronic health condition, there are still people who, while young and healthy, become severely ill with COVID in a way that can't be predicted. So yes, get the vaccine. And if you have been infected, natural immunity provides robust protection, but it is not complete. The best way to protect yourself fully is the combination of natural infection, if you have had it, plus the vaccine. There is a cumulative benefit immunologically to those two.
Thank you so much. I just want to, before we leave this afternoon, I would just like to remind you, if you could please take our brief survey to give us your opinions and rate our webinar today with our three wonderful panelists, Dr. Westlake, Ms. Phoebe Walker, and Ms. Doris Harris. Also, thank you so much for coming this afternoon. There will also be a recording of this webinar available on PHI's website in a few days. Yeah, so thank you so much. Have a great weekend. Stay safe, get vaccinated, and there are several resources that are available in the chat before you leave if you wanted to copy them and save them for later, about the wastewater, about where to find resources, and a link to the survey is also available there.